It's good to be back among friends. We've got some DPC legislative updates and then some more high-tech discussion and ways you can sort of fight the system, so to speak. And it's oriented toward how your patients fight the system and how you help them, regardless of what your specialty is. That's what we're going to dig into today. So there's number 1, 2, and 3 of our objectives. In the past, I've discussed how to define DPC as outside of insurance, and that's been done an awful lot now. And so this time we're going to focus on some of the newer pilot discussions because there are some mistakes being contemplated there that need to be gotten into. And then we're going to go over HITECH, which I've discussed at length before, and there's also a handout in your packet this time. It's a little 4-pager, 2 pages front and back, and it should be a good reference for you and for your patients too. All right, so for those who have not heard of direct primary care, it's a method of, was originally family medicine, but it's used across a lot of specialties now, where if you're providing ongoing care on a chronic basis, then doing itemized fee-for-service is a bit maddening and inefficient, especially when you've got a third-party insurer getting in the way. And so we didn't want to be labeled insurance companies, and to not be labeled insurance companies, we had to define ourselves as outside of insurance, just like the health sharing ministries did prior to DPC. So there's the general definition. Here's what things are starting to look like now. I've got a map on the next page where this is summarized, but about 25 states could arguably say they've already crossed this threshold. There's another 5 that have guidance. So we've reached that tipping point, and I would argue have crossed it, and that there's 30 states where either via legislation or via guidance, DPC is clearly outside of insurance, and there are 8 others that have proposed law in the books right now, and it's being discussed in those states. I'm not digging into detail there. We could get into it in Q&A if people have specific questions. I think Arizona is the one that I might highlight the most, in that they already have law in the books, but as you'll see on the next slide, they're a yellow state, meaning it really wasn't written in a way that would have much effect. So they've got a nice repeal and replace that is hopefully going to pass. The Medicaid pilots are what I am going to cover in a little more detail. The purple states there are ones that take it or leave it. The red ones need to be stopped, and the green ones should probably get your support. And then state employee pilots, those are often done without legislation, and they've been attempted mainly for union groups, actually, in New Jersey, so it's not the first place you would have expected to see it. Okay, so here's the map. A lot to take in here. The green, yellow, or red are states that have already passed DPC defining laws. The purple ones are where insurance commissioners have provided official guidance. Montana is my favorite story there because the insurance commissioner was formerly in the legislature, tried to get DPC, not insurance legislation, passed. It got vetoed by the governor twice. He's in a state where the insurance commissioner position is elected, so he got elected and he wrote his own guidance. He also lost a federal campaign for Senate, unfortunately. But and then you look at the pilot states; those each have stars. If the pilot program passed, it's a pink one, and if it's proposed, it's orange. So that's the overview right now. So what happened in Michigan? This was the first state to have a DPC pilot program passed. They're gathering data. They're not quite there yet. They have a total health care group, abbreviated THC, which is confusing, that partners with DHHS, and they're tracking this data and they're going to present it, but there's nothing yet to talk about there. They're going to come out with quarterly reports, and I pulled the first few, but it's just not worth summarizing yet. Minnesota, they have a House Bill 718 that is oddly phrased in that it gets DPC attention because it sounds like it's going to be DPC, but then it fails to specifically mention it in many passages. And really what they're doing is they're publicly stating that they hate their Medicaid managed care right now, and they want to get rid of it. And they're not quite sure what they're going to do, but they want to give the commissioner a lot of leeway. So if they appoint a good commissioner, this could be an interesting pilot. If they appoint a lousy one, then it's not going to go well. Because they're giving this commissioner the ability to basically say what monthly fees should be, They go on later in the legislation to say that you have to include emergency treatment in this, which is a total misunderstanding of what it could or couldn't be, and in fact contradicts with their own proposed DPC law in the books, where you basically are saying you're not going to provide emergency care. This makes one of the more common mistakes that I've seen in some of these pilot proposals, in that it starts to confuse DPC with an HMO. DPC works because it's a selected marriage. HMOs failed because they were an arranged marriage, and when you confuse those two things, you ruin the model. So Minnesota, in summary, they do have some price setting. The rules vary quite a bit based on what the commissioner does or doesn't want. And this is their Medicaid pilot. It's proposed. It's not on the books. I want to be clear about that. None of these, the rest of the pilots that I'm discussing here are proposals. And then the patient's left out of the monetary transaction, which is another big one. So here you have the commissioners basically contracting with a practice for a given set of patients, and they're not paying any portion of the fee, and hopefully they're at least selecting the physician, but that wasn't clear either. So Indiana, which is maybe more troublesome to me than Minnesota, because they actually were focused on direct primary care, and they already have state direct primary care law in the books, and they use the phrase direct primary care, still didn't get it right, not in this proposal. So they've got lots of arbitrary categories. They're engaged in price fixing. There are formulary mandates, so you have to use drugs that are on formulary first, theoretically regardless of price. There are prior authorization mandates, and so you are obligated to fill those things out, which if anybody listened to Greg Zidiak, we know that's not the truth. And they didn't reference their own DPC law, which was kind of clumsy. So they've made the mistake, in my opinion, in this proposal of sort of becoming, pushing DPC back into the HMO setting rather than embracing it for what it is. This slide here is not necessarily a problem. They were modeling themselves after Michigan, which for some reason felt it necessary to cohort patients in this manner to track data. I don't necessarily have a problem with that. But here's where we get some of the bad language, and it's in red. So they're price fixing, and they're setting a ceiling price is what they're doing. Charge an average monthly fee to a participant of not more than $70. They're going to contract with the office. They're not talking about the patient there. They're talking about their own office. And they're going to only provide primary care services, which must include telemedicine and same-day or next-day business appointments, which most DPC practices do that, but not all, and it depends what fits your model and what doesn't. And it's an unnecessary limitation and restriction. A direct primary care service provider must do the following in Indiana if this pilot were to pass and you were to participate. So I'll let you see that. That's there for your reference too. I think I've beat up on Indiana enough. Hopefully they will change this and do something more like Oklahoma, which is going to be coming up later. Missouri, I had a purple flag on them earlier. They're proposing a Medicaid pilot as well, and they used a lot of the language that I saw in Indiana, but then they tempered it quite a bit and changed some things. So it's a little better, but they still started with some of the language out of Michigan, which caused problems for them. So they're proposing a 5-year pilot. They're going to use 3 different counties, and the counties have to be within these sizes of population. I really don't understand that. I don't know if anybody from Missouri could comment on what was going on there, or who would fit in those ranges in the state of Missouri. I'm not sure. But those are the 3 counties that would be selected. They got to land in one of those categories of population. And again, they're price fixing. They're setting a ceiling, which is a problem, and that's highlighted there in red. They use the same set of categories that we saw earlier in Indiana, which were also seen in Michigan. And then they had some language here that was problematic. The direct primary care provider shall be authorized to provide the pilot participant with access to non-primary care services in the managed care provider network. What's that sound like? HMO gatekeeper, right? So we're still digressing the wrong way here. And here's a little more language out of Missouri. A managed care provider shall not stipulate any conditions upon it which the DPC provider would alter the direct primary care service delivery model. So it kind of counteracts what they said earlier. They give you this terrible phrase, and then they come back and say, but we're not going to mess with what you're doing. We promise. It'll be okay. So that's the purple stuff where they try and reassure you, and they at least seem to be self-aware that they're stepping in the wrong direction. So it's kind of a contradictory bill in a lot of ways. Virginia has a small, much shorter bill. It's only one page. It's got that in common with Oklahoma, and I think they're both probably worth supporting. They didn't say a whole lot. This was most of their legislation right here in quotes. And I'll let you glance at that. They were using the Section 115 waiver of the ACA to try and give themselves the freedom to do this. They did set a price ceiling, but at least it was fairly high at $100 a month for an individual, or $125, and they were assuming a dual eligible patient would be more complicated than a regular Medicaid patient. So that was the problem. That was the big problem with Virginia's proposal. But otherwise, it was fine. Where they actually did well was they said, you know what, we're already tracking this data. We don't have to put any obligations on the practice because we can see how the downstream spending is in these categories anyway. Oklahoma's my favorite. This is their entire proposal right there on the slide. Notice it's reimbursing the member, which is not the practice, that's the patient. And they're setting a floor, not a ceiling, and it's a floor reimbursement to the patient. So if I'm a DPC physician in Oklahoma, or quite frankly even in Wyoming, and an Oklahoma Medicaid patient happens to come into my office, they might get reimbursed from the state for taking the action of being a DPC patient without me even knowing it. Because I didn't have to contract with the state, it doesn't contemplate whether or not I'm even participating in the state's Medicaid program. So this is a well-written pilot if what the state wants to do is encourage their patients to be DPC members and thus save downstream dollars. So I'll sort of summarize it here. It's got a voucher reimbursement floor. The member notifies the authority rather than the physician. So if the patient joins a practice, leaves a practice, it's their obligation to come back to the state and say it. And that makes sense because they're the one being compensated by the state. There's no price fixing, and the floor is low enough that it's probably not going to cause price inflation. There's no requirement that the physician be enrolled in Medicaid. And they're not tracking any data, at least directly from the practice. They're using downstream spending, which is more objective and more relevant. Tennessee State Employee Pilot. So this one, it's a nice effort, but ultimately they're just wanting to study the feasibility of direct primary care. They're not really taking any big steps here. Nebraska has a different state employee pilot that actually has already passed, but it's kind of like Michigan in that there's not a whole lot of data on it yet. Some things they did right, some things not so much. They called it a health plan, which I hate, given what the discussion we're having with the IRS, and that it's just a confusing term, and it means a lot of different things to different people, so I would never refer to this as a health plan. Primary care services, yes. Pharmaceutical care, no. We've gone out of our way to say that's not the case. When you're doing in-office dispensing, you're technically not acting as a pharmacy. That's an important exception. Medical specialists, hospitals, other medical coverage, that's vague and problematic, but they did include that. So they were the first ones to propose this 5-year timeline, and I think that's what Missouri's borrowing from in their proposal. And the payment does come from the state to the practice, which is potentially problematic and a step toward an HMO. And those are the things they're going to use to measure patient engagement. That was something I didn't see in a lot of the other proposals here, and this is a more controversial topic, is if you're going to measure engagement, how do you do it? And I like what Oklahoma's doing, where the patient can simply send in an invoice to prove they're a member of a practice. But if you're going to ask the practice for data, what are you going to ask them for? An HRA is a health risk assessment. That's basically the first visit of the year for any practice, and they'd want to track any kind of face-to-face visit, just simply have a check mark in a box that a visit occurred. And what they want for preventive care or chronic disease management, I'm not sure. So, if we're going to summarize these pilots, you want to look to Oklahoma for guidance. It can be that simple. It's basically a 1 or 2 paragraph law. You want to set a voucher reimbursement floor where the patient is paid, and you want to track downstream data because you're already doing that work. It doesn't create additional burden on the state or the practice. Enrollment should equal an agreement between the patient and the state, because that's what's going on, that's who's getting paid, that's where the money's going back and forth. The agreement between the patient and the practice is left alone. Okay. So one of the other issues that's really important to DPC physicians, and Dr. Page, I imagine she'll talk about it a little bit later here too, since we've got handouts in the packet, but dispensing medications. In Texas, you can't do it. And that's a big surprise because that red state does not match the other red states on this map, at least not usually with these kinds of laws. But it's a flat-out prohibition. Green states make it very easy. Some of the other states have different requirements and regulations, but ultimately this is possible everywhere except Texas, New York, New Jersey, and Massachusetts. So what are we going to do about that? Well, in Texas, there's a couple laws being proposed right now. The first one's House Bill 1622. I think that's the same one that there's a handout on in the packet. And it's going to permit physicians to do dispensing of non-controlled medications, so non-narcotics, not your opioids, not your benzos, not your stimulants, but for the other things that aren't going to appear in the state database of controlled medications, you can dispense them. You need to notify the patient that the traditional pharmacy is also an option if they want to overspend. And the confusing part of the law, which I think is done to help get it passed since it seems to have a lot of movement this year, is that you get to register with both the medical board and the board of pharmacy. Most states, it's either one or the other. Ideally, it's the medical board if there is a registration, since that's who's typically policing you. In Texas, it's both. And that means if there's a fight between the boards, who's going to win? I'm not sure. I would hope the medical board. It didn't contemplate a fee. Some states do have fees. Maryland has the highest I've seen. I think it's $1,000 a year. Most states that do have a registration process do so without any fee whatsoever. If you're looking for a state, if you say, I want to be on the front end of this, as soon as this passes, I want to dispense medications, and you're sort of looking for a process to follow, Georgia, I've got them linked on DPC Frontier, actually has a helpful process if you're just developing your own policies that they recommend. Okay, so what's going on at the federal level? Health savings accounts have been the big topic for many years now. Primary Care Enhancement Act is what we've been pushing at the Direct Primary Care Coalition, and DPC Alliance has supported that. Several different groups have supported that over the years, and it's going to be reintroduced. Last year, it was manipulated in ways that we'll get into in a moment, so that not everybody supported it, which was understandable. This year, there are already 3 other laws that have been introduced, even this early, that sort of contemplate HSA corrections. I think that we should focus our attention on the Primary Care Enhancement Act, though, because it's going to contain a full correction, which most of these other ones do not. H.R. 457 does, but it won't get the same attention. So what's the point behind an HSA correction? What's the big deal? The IRS views DPC as a type of plan. And because it's a type of plan to them, simply being a member of a DPC practice means you're not eligible for an HSA. That suddenly you have a second plan which has a next to zero deductible, you can't continue contributing to an HSA. That's the 223C gap plan problem. The 213D problem is, even if we admitted that this wasn't a plan, you're paying a monthly fee. To me, that doesn't look like a medical expense because it doesn't have an EKG with $20 next to it or some sort of itemized line. We can't tell what you did, so we're not going to consider this medicine. I think that's the far weaker argument of the two. The IRS has not tried to litigate these and have not indicated an appetite to do so, but nonetheless, it gets in the way of the growth of DPC. So the legislation that's been proposed is trying to correct these two problems. Originally, that's all we did, and then the language was changed quite a bit in squirrely ways that didn't make sense to me or anybody else, except a handful of people on those committees who were pushing them. And the biggest one that got in the way last year was that they were trying to put a cap in the amount. And arguably, the cap was done to make it score lower so that it could get bipartisan support. But they decided to put the cap in the definition of direct primary care because they also wanted to achieve a scope restriction with a monetary decrease in how much you could be paid. So the theory was, if we limit you to only $150 per individual per month, then we know you're not going to do these surgeries we don't want you doing. So it was rather bizarre. So this year, it's going to be reintroduced. That is going to be pulled from the language If there is a monetary amount, it'll be focused not on the definition, but instead on how much you could simply spend out of the HSA. So on to HIPAA. When a patient comes into your practice, they've got a notice of privacy practices that they may or may not choose to sign. But more importantly, HIPAA was modified by HITECH, and HITECH is the sort of Swiss Army knife for price transparency through the rest of the system. Because a patient is allowed under HITECH to demand of any HIPAA-covered entity that they give them a cash price. Doesn't mean you get a good cash price, but it means you get a cash price. It means regardless of your insurance, you can come in and say, I want to pay cash for this. My DPC doc said this MRI was going to be $350, and I don't want to be hosed over by your fake $1,000 price with the insurance company. I want this real one. So HITECH's what allows patients to do that. I've got a lot of sort of referenced language here for you to use, and this is also in that handout, the 4-pager. There's a summary of this. So I'm going to hop over some of the denser language here and get to the more interactive pieces. So what about an HMO? What about exceptions to this? What about Medicare? What about Medicaid? With an HMO, if the HMO contract says you can't do it, that's garbage. It doesn't matter. If the HMO state law on the books says you can't do it, then it trumps HITECH. Everybody understand the difference? So HITECH has a little bit of a castration clause in there that says if there's another law that conflicts with ours, then you're going to have to follow that law. And then they had several carve-outs. So the HMO was one of them. If the state Medicaid provider manual prohibits you from privately contracting, such as Kentucky or Colorado, then that will trump HITECH. But anything else, including Medicare patients, HITECH wins. So even if you've not opted out of Medicare, you can privately charge a patient if they, of their own volition, say, I want to pay you cash for privacy. This is not the panacea you're hoping, because it doesn't mean you can pick your own price. You still have to document the same way. You're still limited to the Medicare limiting amount. But it is an option. Okay. So actually implementing it, there's on the very back, there's a little paragraph on the end of that 4-pager that sort of says it's a provision that you could give your patients, and they could go into any hospital system and demand to use this. All right, so there's there's sort of a privacy summary page under HITECH. And this is another summary for you, so don't use it as a way to say, I don't need to opt out, I can just have all my patients do these HITECH things. Because it needs to be of their own request. Okay, so if you're dealing with a consultant who's not helping you out and you've wanted a question to be answered, you can have your patient go in and say, even though you're hospital employed, I want to use HITECH, and if they won't do that, they have to do that if they're a covered entity. If you're not getting your clinical questions answered, send them in with this 1-page summary of what you want, offer to do a telemed visit where you're participating in the entire visit with them, and hold them accountable for an efficient answer, and avoid that referral wheel that so often happens where you send someone in to see a physician and instead they see their mid-level provider who refers them to somebody else in the system, and then you find out 3 weeks later after they've seen 3 other physicians and have spent thousands of dollars. If you're fighting the insurance plan, don't fill out a prior auth, use Greg's IDX method. He's presented that in a prior AAPS event, and it's excellent. There's some case law citation there for you too that he uses. If anybody's going to fill it out, it ought to be the patient, and they ought to be calling and screaming at the insurance company the entire time. If there's a procedure, consult, or medication that's denied, ask for the name of that physician reviewer and report them to the medical board. Certainly if they don't have a state license, they're asking for it. If they do and they got in the way and it was bad enough, then that's another technique you could take. We don't like having to do this to fellow physicians, but if they're, in your opinion, harming patient care, then that's the action you can take. And if enough people do that, I think physicians will stop doing these roles that maybe they shouldn't have been doing in the first place in helping out an insurance company. If you're fighting the hospital, this is one more important exception that I don't think we covered before. You can plan out certain things in advance, right? You can negotiate probably 90% of the surgeries you're going to have because they're not emergencies. But what if it is an emergency? Then you want to know what a price transparent procedure should look like, and these are some examples. And then when you show up at the ER, you want to mention HITECH, which they may or may not have time for, or you may or may not have the cognizance for. And then after the fact, the court system actually helps you out here. Since it was an emergency, you're allowed to argue that regardless of what that hospital's price was for the procedure, that you're only going to pay them fair market value. This was an agreement of adhesion. It was signed under duress, if it was signed at all, and fair market value rules apply. So you can use these guys to argue what fair market value actually is, just like you could use Medicare rates to argue what fair market value is. So your ER process, show up, demand HITECH, demand Medicare rates. If you're a member of a health share, you don't even need to disclose that to them, even if they say that you have to disclose it, because technically that health share has no contract with that hospital. They will help you find a transparent price after the fact. And tell them you'll see them in court. Ideally small claims court, because they usually won't show up, and then you get an easy victory. Thank you.